colleague from all my late night texts and questions, Dr. Jessica McMichael. Hi, Jessica. How are you?
Good. Thanks. Hi. Thanks for having me.
Thanks for being here. And I never call you Jessica because I'm so honored whenever you're giving me some tidbit of information. I want to be proper and address you as Dr. McMichael. But I'm just so excited to know you as a person and a physician. I'll try to make this really short because people can go to your website to learn more about you. But you are a pediatric orthopedic surgeon. You worked in orthopedic trauma, and you're passionate about the care and treatment of fractures and a variety of pediatric musculoskeletal disorders, including limb deformity, foot deformity, and cerebral palsy. You earned your medical degree from St. Louis University School of Medicine, where you completed your residency, and you served as an orthopedic surgeon in the United States Air Force and was adjunct faculty at the Center for Sustainment of Trauma and Readiness Skills in St. Louis, Missouri. Dr. McMichael completed her orthopedic surgery fellowship at Shriners Hospital for Children, Northern California, UC Davis Medical Center. So today we decided to speak about some very high yield topics that I see in my pediatric office and that come up quite frequently in the community and in your office. And you were nice to lead me in the direction of some of the more frequent things that get overlooked. And definitely a hot topic in the last decade is hypermobility syndromes. Can you describe what those are and what people need to look for them and the implication for pediatrics?
Sure. So actually hypermobility is very broad. It's a kind of a generic term, and hypermobility is really common. It's really common in the general population. So not everybody who has hypermobility has a pathologic problem. So people might, understand hypermobility in terms of being double jointed, they'll have had like party tricks throughout their life where they can, make funny shapes out of their hands and arms and everything. And so it's not always a problem. And people usually come to me when they have kind of gotten through enough of life where they start to have some kind of issue. And it's basically joint pain. It's sometimes dislocations. So I don't want people to be afraid that hypermobility means they have some kind of a pathologic problem. Now, there are some inherited genetic type diagnoses that have hypermobility as one of the signs. And the main one that we deal with is something called Ehlers-Danlos syndrome. So if anybody goes and Googles Ehlers-Danlos syndrome, they're going to get kind of inundated with a bunch of information, some of which is quite scary. So I don't recommend doing that. Just go and look it up.
Google search.
It comes on a spectrum, and it can be very, very mild or actually very severe. And so it's really difficult to kind of, you can get yourself down a rabbit hole of scary information if you don't have it evaluated by a qualified professional. So honestly, for the most part, the kids I see in my practice are kids with kind of benign hypermobility. And so we don't often do much about it. We just do a lot of physical therapy, because one thing that is in somebody's control is how strong the muscles are that support the joints. So if you can maintain a lifestyle where there's, the least amount of stress on the joints as possible and keep them strong, then that's pretty much the best we can do. Now, with Ehlers-Danlos syndrome and some of the other more rare conditions like Marfan syndrome, Osteogenesis Imperfecta, homocystinuria, there's all these other ones that have hypermobility with it. They will sometimes have other signs. There may be some cardiac abnormalities, sometimes vision issues, because it's a collagen issue. And if your collagen is not healthy, then the collagen is in so many structures in the human body. It's in your eyeballs, it's in your skin, vessels, bones, teeth, it's everywhere. So collagen, if it's a true collagen disorder or a connective tissue disorder, then that falls into one of those other categories. It's not benign hypermobility.
So yes, after going through medical school and learning about exam findings with hypermobile joints, I tend to see it so often, and I don't really know, even as a pediatrician, at what point do we, because we're at the brink of a genetic, I guess, new world where we can actually find out what is a true pathologic condition and whether or not it's related to certain what's going to happen in the future for you by the interplay of several genes and not. What would you say would be the biggest reason for a parent who has a child who's we call it double jointed, right? We know that they can put their thumb to their arm, or they're carrying, they can pull their arm. They're almost like a contortionist, extremely good, break dancer. What would be a reason for a parent to seek a specialist or talk to their pediatrician about it?
If you've had joint dislocations, that's definitely a reason to refer to an orthopedic surgeon. If you have other things like, hypermobile skin, there are some people where, like, if I pull on my skin, like I can't pull it very far, but people with Ehlers-Danlos with certain types, their skin just goes more like that. So you could look at the kind of the texture of the skin and how extensile it is. There's also kind of like a quality to the way kids scar. So if you're noticing that the scar is very thin, like almost like the cigarette paper. Ooh, dare I say the word cigarette on a medical show. But like that paper that used to be on cigarette packets back in the day, it's that real thin kind of cellophane-y type quality.
Yeah.
That could be an indication. Any kind of like heart murmur or cardiac problem. I actually at times will just go ahead and refer some of my kids to a cardiologist for a cardiac evaluation, but we don't want to react to every single hypermobile thing because it's going to be a lot of people. So it's just a matter of putting the pieces together. And then for EDS in particular, a lot of times they'll have this constellation of symptoms that is characterized by POTS, which is this postural hypotension, where they get faint and they pass out. Sometimes they'll also have and I'm not an expert in this, so I'm going out on a limb here, but sometimes they'll have other things, like they'll get hives easily or have what people are calling mast cell activation syndrome. And it's like they kind of come together in this interesting, probably it's a mixed connective tissue disorder is my thought about it. But you'll notice they will kind of have other things that's just beyond being kind of loosey-goosey.
Okay. There sounds like there would be a number of red flags. So children dislocating their elbow or like a nursemaid's elbow twice, that's might just be the parent pulling on it. But once you see more issues coming up.
Yeah, so that actually brings up a good point about age, because nursemaids' elbows are most common between the ages of 2 and 4, and I've seen them up to about the age of 7. Less rare, less commonly, but 2 and 4 is where the majority of them happen, and that is completely benign. It's super common. Nursemaids' elbows happen all the time. It doesn't mean anything. And actually, kids from toddlerhood up to about the age of 4 do have looser ligaments, and you'll notice that if you just look at a little kid's foot, a little toddler, and they all look flat-footed, and then all of a sudden as they grow a little older, their arch forms. It's just because they're going through a period of hypermobility. That's normal.
One thing I noticed with my own children that I reached out to a friend who was a pediatric orthopedist about was the clicking that happens after picking your child up again and again under the shoulders. And I realized I could help that and change that just by, he said, just don't pull them up that way. And of course, I grab by the ribs and that everything's solved because they're not pulling, but you really don't want to do the repeated traction, even though it's normal, right? Is there an issue? I mean,
I picked my kid up by her armpits all the time, so I don't know.
You weren't hearing clicks or is it just not, not a concern, right?
So, there was never any, it's easy for me to say because I kind of know what feels normal and not normal. So little clicks here and there don't bother me at all. And you'll find that in ankles and hips and knees and ribs and everything's clicking because we have nitrogen in our bodies, and nitrogen creates little bubbles, and that's why we can pop our joints. So there's no reason why that won't happen in a child too. But if you're noticing like a dislocation where the child is then crying, the child's bothered by it, that's completely different.
Okay,
in
good.
my opinion. Mm-hmm.
So you're helping me help my patients as far as not over worrying about anything.
Mm-hmm.
So any other overlooked musculoskeletal disorders you'd want the public to be aware of that they should? It sounds like you've given us a good background of things to look for if there's multiple issues.
I know we had osteogenesis imperfecta on the list, and that's not really like an overlooked disorder. That's a highly studied disorder. It's usually pretty evident when it presents, but generalized bone health, I think, is overlooked. And your childhood is the only time in life where you can really, really make deposits of minerals into the bone bank, which is a human skeleton. If we're lucky, that lasts until about the age of 25, maybe a little bit later. And so it's important that we educate people on vitamin D and calcium. I'm more kind of strict about the vitamin D because vitamin D deficiency is an epidemic, in my opinion. Even in places like California where we live, where it's sunny all the time, kids use a lot of sunscreen and they're not really getting enough exposure to have normal vitamin D levels. So vitamin D is just so important. And I recommend vitamin D supplementation.
I want to take this opportunity to tell the viewers that I will screen everybody starting at 4 or whenever we will do labs for vitamin D, and the darker your kid is from surfing in the sun almost correlates with a lower vitamin D. Kids who are outside all day will still have low vitamin D. And what is low in my book? Even close to 30. We want you closer to 100. So if you're at 30, that's not a reason to say, oh, everything's good. That means you got to work a little harder. And children should be on at least 1,000. Babies are on 400, but it really takes a lot to have vitamin D toxicity, and you need to take it with food.
I completely agree. And I talked to a pediatric endocrinologist recently about, recommended dosing. And she said, there's really no agreement, but it's so hard to overdose on vitamin D if you're getting it from a reputable source that it's so unlikely to develop hypervitaminosis D that supplementing even high, I take probably 10,000 international units a day personally. And then I have my child on 1,000 international units, and she's going to be 8 in a month. It's really just the only time in life that we're going to be able to build this. Now, calcium's a little different because it's not every kid is, it's not benign for every kid to take a bunch of calcium, and there's a risk of kidney stones. And so I just leave that up to pediatricians. So I don't push the calcium as much as the vitamin D personally.
I always hand out some great sources for calcium. You wouldn't believe how much you get in tofu, beans, spinach. There's some great hidden sources of calcium. I have always shared some handouts with my patients. So you can find it in food too. It's
important to note that calcium is more readily available to the human body through food, whereas vitamin D isn't. And so even if our food is supplemented, it's still not enough.
So true. And you can find great levels of vitamin D in salmon, etc. And milk, you'd have to have so much that you would be sick to your stomach. And then the people who say they're going to get it from being outside, well, you're going to have skin cancer by the time your kid's 20 if you get the right amount of sun needed to get that vitamin D. So there's no way around supplementing vitamin D. It's linked to the immune system. Obviously, it's always been known for its effect on the bones because it was studied as rickets in England. And then it has great effects on it being anti-allergies and mental health. The list goes on and on.
Yeah. And then, so the only other thing about kind of questions that come to me from parents, if their child has what we think are frequent fractures, and, people get really worried if their kid has some kind of a metabolic bone problem. And my rule of thumb is if there are 3 or more fractures within 12 months, regardless of the mechanism of injury, that child, I recommend getting laboratory workup for metabolic bone issues. And then we refer on to a pediatric endocrinologist as needed. But, kids are kids and they're crazy and they're just doing stuff. And so if your child breaks something when they fall off the roof, that's a normal reason to break a bone.
Yeah.
Snowboarding, mountain biking, hoverboards.
That brings us to something I really want to talk about, because that's the call the pediatricians get all the time. Is it fractured? Do we go to the emergency room? What do we do? And almost every parent is going to experience that 2 or 3 times. Is this a sprain? Is it a fracture? Do I need to go to the emergency room? Well, can you speak to that?
Yeah, absolutely. So the first thing that I would look for is the child's response to pain. Is the child calm? Is the child consolable? If you give them a little bit of Motrin or Tylenol, does it seem like the child's just pretty comfortable? That's my first clue that things are probably okay to wait until the next business day. If you're looking and you see a little swelling, but it's not really grossly deformed, that's another really good clue that it would probably be okay to wait until the next day. But if there's any deformity, which is usually pretty obvious, or if the child really is uncomfortable and cannot be consoled with really ice or just a dose of Tylenol, then I think that would be a reason to present to the ER or an urgent care. There are some urgent cares that are amazing and they are really, really equipped to deal with pediatric fractures, and others that aren't. So that's a little bit of a gamble, I guess. And then if it's really, something with a deformity, then that we usually like to do what we call a reduction in the emergency department. So if you present to a facility that isn't really used to taking care of that sort of thing, they're going to end up transferring you to somewhere that is. And that would either be probably chalk admission or chalk here in Orange. There are some hospitals in the outlying community that feel comfortable doing, a reduction of a bone. So that's also a little bit hit or miss.
And parents can always call in advance and ask them for that age.
Yeah, absolutely. And then the other thing is we try very hard in my practice to accommodate same day appointments. So even if your child is hurt, say the night before, and you call at 8:00 in the morning when the phones get turned on, we can usually accommodate you. We work very, very hard to accommodate people same day. And then if it's, say morning time that somebody gets injured, and if you want, you can call the office and see if you can get accommodated later in the afternoon rather than making a pit stop at the urgent care first. You can always try our office just to kind of, try to streamline things. But one thing that does happen on occasion is when somebody they know that, and they come to us and we get an x-ray in our office, and then it is something that needs to be treated. So then we send you over to the emergency room from our office. But at least then you're going to the right place, and still
when
probably.
You say treated, you mean reduced versus.
Correct.
Yeah. And then the third point I was going to add to needing to go to the emergency room is if there's an open wound near the fracture.
For sure. Oh yeah, that's a good call. Yeah, absolutely.
Might be more obvious to people. And then I want to piggyback on what you're saying. The truth is if your child, baby can fall asleep with minimal analgesic like Motrin, usually you want the swelling to come down and you can splint it at home. And regardless, they're not going to put anything in a cast until the swelling comes down anyhow. So you're not necessarily, if you can talk to your pediatrician and you're comfortable with what the pediatrician tells you, it is okay to wait and not make that trip to the emergency room with the guidance of the on-call pediatrician. And then they can usually contact the orthopedist in the morning or that evening for you.
That happens a lot too, where the family will present to their primary care doctor, and they'll call us and say, hey, and sometimes the primary care doctor can get an x-ray in their office depending upon what kind of equipment they have. And then they just forward us images then we can kind of dictate what to do from there. And it's really helpful, especially, in these coronavirus times where people just really don't want to be spending time in the emergency room.
So getting to the point of sprains versus fractures, if somebody's comfortable enough, there's always the Ottawa rules. If you can't take 4 steps, you better go in to see the orthopedist. But if someone's comfortable enough that they can get through their school day and just keep it splinted, what I like to tell them is after day 3, if it's starting to get a little bit better, it's not a fracture. Is that fair, Dr. McMichael?
I mean, sometimes it is, but kids do not follow rules, as you know. There are some kids that have a broken wrist, let's say, and they are fine. And it's because of the really thick periosteum that covers the bone. Sometimes it doesn't even look that swollen. And so then we'll, kind of see a little bit later, they might not be complaining of pain, but say the parent notices they're just not using their arm or something along those lines. And sure enough, we'll find a fracture. But chances are, if they're not really complaining about it and it doesn't look deformed, chances are it's either a sprain or a really mild fracture that's going to be stable anyway. It just, at some point you have to make a decision. Do we want to x-ray this or not? So I think that's probably what you're getting at.
Yeah. And at what point do we rush over to the orthopedist? But it sounds like you guys are happy to see them regardless, just to make sure. Now, do you guys use digital x-rays? That's always been a fear of my patients. They don't want to get the x-ray if they don't need it.
Yeah, of course.
You use digital. So can you explain the difference? Because that's actually not commonly understood by patients.
Well, I mean, the x-ray beam is directed at, I'm just going to use the wrist as an example. It's like directed here. The most absorption happens at the skin and it scatters a little bit. We do use lead cover in my office, but
I didn't want to make it so complicated for you, but just how low the dose of radiation is with digital versus the old school that we grew up with. So I think that needs to be explained to the public.
Yeah, I tell my patients to expect about the same amount of radiation that you would get in the atmosphere in 3 days.
And that's
because there's radiation in the atmosphere all the time. And so when we do our radiation safety training, which you have to get a license for it in the state of California, we always use the principle of the lowest amount of radiation to get the information that you need. And then also the common example that's used in that radiation safety training is a chest x-ray, which to me is actually like more space and a bigger beam, like,
with more vital organs. Yeah.
More vital organs. And the common kind of description is that's one single shot for a chest x-ray is about the amount of radiation you'll get in 3 days from the atmosphere. And then other people say things like, oh, it's the same amount of radiation you would get if you flew from California to New York on a jet airliner. So people are doing these other things where they're radiation all the time without any thought about it. And then the amount of radiation that you're getting is quite low. There's just a problem with that, is that nobody really knows what the dose is that causes a problem. It's not likely, but we can't say for sure.
Right. But it is a big change from if somebody hadn't heard our conversation, prior x-rays when we were younger were 100 times more radiation. Yeah. So the take home point is that exposure is so minimal.
Yeah,
not that it is an x-ray, but it's just not the end of the world to get one. And often it will happen in the orthopedic office just to have on hand for it. Yeah. And then do you want to speak a little bit about the things we see in toddlerhood and the start of life with the different shapes of the feet and the legs, bowed legs, in-toeing?
So I wanted to call your attention. I found this publication that's really recent, and I wanted to give it to you if the listeners want to look it up.
W sitting, right? Is that what
it's on W sitting? I'll give it. Are you going to make a post after this, or is there any other follow up to it?
I can add it too. If you tell it to me, I can add it to our screen. We can Google search it.
I had it pulled up and then I lost it. But anyway, there have been two.
Oh,
Two recent publications, both in pediatric journals, not orthopedic journals, where people have dispelled myths associated with some of the common things we see. So it's W-sitting, flexible flat feet, and in-toeing and out-toeing. Those things are extraordinarily common, and they end up resulting in a lot of unnecessary x-rays.
Oh, no.
Like really unnecessary x-rays, and actually treatments and interventions that really have no bearing on the natural history of the conditions. So I'm always happy to evaluate somebody and provide reassurance, because reassurance can really go a long way. So in-toeing is kind of the sum total of what's going on between the hips, the femurs or the thigh bones, the shin bones, the tibias, and the feet. So you can have increased femoral rotation or femoral anteversion. You can have internal tibial torsion, and then metatarsus adductus, or any combination of those things to create an inward appearance of the feet. The tibial torsion resolves by about age 8, usually, not always, but usually. The femoral rotation can resolve as late as the early teens. So the metatarsus adductus typically resolves before the child walks, but there are some people that still have like a sort of like a kidney bean shaped foot. None of them are pathologic unless there's some kind of underlying neurologic problem. And people, I think about 30 to 40 years ago, were getting treated with braces and the Dennis Brown bar for those things. And it turns out that if there's a natural history and they just resolve on their own. And so a lot of times now we'll have a new parent, but their grandparent is like, you have to get this fixed.
Mm-hmm, mm-hmm.
And we've just evolved in what we know about it. And so I have never prescribed.
Yeah. My husband has this, it looks like a rocker with these 2 leather white shoes. Mm-hmm. And he ran track at Cal. You know, he was in-toed and fast, and I don't know if it made a difference in the end, but
it's interesting. It's interesting you say that, because if you look at sprinters, like world-class sprinters, Olympians, there's a greater percentage of them who are in-toers than the general population.
Yes, and their weight falls right under them. Yep. I tell that to my patients and they get worried.
So I think it's a cosmetic issue more than anything, but there are some instances when a child is, older, when all that natural history should be resolved, and it hasn't resolved. So if they're falling so much that they're getting concussions or bloody noses or ankle sprains, recurrent ankle sprains, and I'll fix it. It's just, you have to break the bone, cut it with a saw and rotate it and fix it with metal. So that's not like great to do that.
And can you speak about, I know you have to run to the OR real soon. Mm-hmm. Did they call you? Are you okay?
No, I think we're good. They're going to text me.
And then as far as you can maybe touch on toe walking, at what point is it not normal and how much is normal? And then flat feet, I try to tell people we don't do orthotics for children. We let it be. Mm-hmm. But go ahead. Yeah. You let us know what you know about it.
Yeah. So flat feet, as long as they're flexible, then I don't consider them pathologic. And there's a very large percentage of the population that has flat feet. That's absolutely not a problem. If it is stiff or rigid or there's pain, then I do work that up, because sometimes the patient will have something called the tarsal coalition or some other reason to be stiff. So that's different if it's stiff. Flat feet are very, very common around the age 2 to 4. And so I don't worry about that at all when kids are that young. There was one other thing you asked. I'm sorry.
Toe walking.
Toe walking. Oh, yeah. Oh, I love talking about toe walking.
Yeah, I see it so much.
Toe walking is also a part of normal toddlerhood. Some toddlers toe walk. It's not a problem. But if the child gets a heel cord contracture or an Achilles tendon contracture, it can be kind of hard for them to go flat-footed. So those kids I will refer for therapy and some stretching. But toe walking, if it's a part of natural development. Go ahead.
Sorry. Is a heel cord contracture different from an Achilles contracture, or are they one and the same thing? Okay.
It's the same.
Go ahead. Uh-huh.
So then if they're beyond toddlerhood and they're still toe walking, I start to kind of think about that. Like age 3, I'm thinking, why are they still toe walking? 4 really shouldn't still be toe walking. And 5 is when I really recommend we intervene if they're still toe walking. And then if there's any sort of sensory processing condition going on too, sensitivity to light, sound, texture, things like that. You don't even have to have like an autism spectrum disorder, but just like a sensitive kid. So it's ASD, autism spectrum disorder, kids with sensitivity, like I just described, and then also kids with ADD and ADHD. Though they are very often the toe walker. If you have one of those with toe walking, it usually won't go away on its own. So it's not like that so-called idiopathic toe walking that we always used to describe. We don't think it's idiopathic, really. We think there probably is this like neural pathway that just happens to tell this person to walk on their toes. So when I treat toe walking, I describe it as like 2 separate issues. We have ankle range of motion, which is required to walk heel to toe. And that doesn't extinguish toe walking. Like I can work to get you your ankle range of motion as the orthopedic surgeon, but I cannot make the child create a new neural pathway. That new neural pathway has to be created in order for the patient to not walk on their toes anymore. And that comes with thousands upon thousands upon thousands of repetitions, which is a lot of physical therapy, sometimes bracing, sometimes casting, just to prevent them from going up on their toes. So it's getting the repetitions. I don't often have to operate on kids for toe walking, but sometimes if their ankle tightness is so severe that we're not able to stretch it out, then sometimes I'll do surgery. And you might wonder, like, why do we even care? Like, who cares if people walk on their toes? What's the big deal? Well, it overloads the forefoot. It causes forefoot splaying and kind of that increased callus patterning on the forefoot. And then also as a child spends more and more time up on their toes, there is this mechanical stress on the tibia or the shin bone that causes the bone to grow external. So then once the child comes off their toes, now they're walking with their feet out or out toeing because the bone changes. So if we can intervene before the bone changes, and that's ideal.
Do you see interventions for a 3-year-old if they're intense? What % of the time do you see they're successful if they really are doing the exercises? Is it 100% or?
It depends on the effort of everybody. And I always describe it as a marathon, not a sprint. So it's really successful if you follow through. It just requires so much effort on the part of the family to follow through and be consistent. So as long as people do that, I mean, I would say it's pretty darn successful. I don't know about a percentage, but I'd say like 80s, 90s if people really, really follow through.
And I think people could probably, parents who do notice this habit could probably look up on YouTube. I found quite a few exercises for my patients, or flat foot or toe walking, just ways to start stretching that Achilles for kids.
Sure. And there's a super exciting new technology that we just studied with a physical therapist at Chapman University. It was her idea. We can't take credit for this, but it's wearable technology where this little insert goes in the shoe that causes a little vibration, and it gives them the neural feedback.
I saw that in one of your notes, and I did not know what it is.
Well, it's not available yet. It's being tested, so it's not commercially available yet. But I think it will revolutionize toe walking treatment because we'll be able to intervene with something meaningful early rather than just say, "Oh, go to therapy and tell your kid to walk on their heels."
Is there some sort of shoe or insert now that you
can buy squeaky shoes, but people hate them.
People hate them. Okay. And then a patient came back from seeing you and the physical therapist with the concept of a hiking boot. Is that? I
mean, you can try it.
It's harder to get trained.
It just depends on the degree. It depends on how severe it is. So there's mild, moderate, and severe. It just depends. If they're mild, it might be enough that they have to work hard enough to get up on their toe. But it just depends. It's not going to hurt people to try a walking boot or to try a hiking boot. So, I'm all for stuff that won't hurt you.
Yeah. Can I take your time with one more question that I think is useful for everyone, adults and kids?
Mm-hmm.
It's pretty simple and it will be easy for you to answer. What do you recommend as far as heat versus ice? There's nothing better in this world than ice. I remember in college, the 15 minutes in the ice baths with the football players. The cross country team would jump in for 15 minutes, did it every day, and we were fresh for our next workout. So I love telling people to ice and make sure they don't get, burnt on their skin. We do that for 2 days. Is that correct? Tell me what your regimen is, ice versus heat. When do you use heat? How much ice? As much as you can take, or is there a limit?
So I recommend 20 minutes on, 20 minutes off. Basically, I don't have an end. Like if it feels good and you're not burning the skin, like you said, you can ice as long as you want. Usually it's, if somebody's injured, they're not doing it when they're up and moving around, but it's like in the evening times, when they're kind of resting or relaxing. And I don't want people to ever sleep with ice on or sleep with heat on, because then you really can have some skin damage.
I'm sorry, when you said that there's really no end, you mean no end that you could go 20 minutes to an hour and a half, or no end meaning you can do it for 2 months?
Yeah, right, exactly. So if it feels good and you're icing, I don't think you have to stop at 2 days. You could ice for 2 weeks or 3 weeks or whatever. I mean, it takes a little bit of common sense, to be honest. But as far as how long to ice, I usually don't have people ice longer than 1 to 2 hours at a time. And this isn't based on anything, it's just habit.
Right.
Yeah. As far as heat, I tell people when you're cold, use heat, and when you're warm, use ice. So if something's inflamed and it's warm, they use ice. And if something is cold, like your muscles are cold and you're trying to warm them up, then I say use heat. And my favorite way to use heat is actually a warm bath with Epsom salts, because the magnesium is absorbed really, really well through the skin. And magnesium is such a powerful muscle relaxer that any sort of cramping that might be associated with whatever the injury is can be impacted by that. I also recommend there's a type of magnesium you can get in powder form and make a little drink out of it. I think it's called like Kids Calm or something like that. Kids Calm.
Well, I've never seen the kids version, but it's just Calm.
Yeah, there's a kids version at Sprouts. It's like
great. Awesome.
Whatever dose for children. It doesn't taste great, but
No, they have gummies. The same brand has gummies.
So, I mean, I think to myself, if magnesium is powerful enough to stop labor, it's going to help muscle cramps. You know what I mean?
I love Epsom salts for everything.
Yeah, I do too. I actually take an Epsom salt bath basically every day myself.
Well, good for you.
Yes.
Getting time for a bath. I'm jealous. I still have the little ones putting in the bath and have to wash. So if it's cold tight, use heat. And how would you apply that to an ankle sprain? That's the most common question I get, ankle sprains. Do I put heat on it right away? I think the whole concept of healing from an ankle sprain has changed since I was in basketball.
Yeah. Usually if it's like an acute injury with swelling, I have people ice it. But if it's something that they're rehabbing and they're trying to stretch and trying to get through the rehab phase, I use heat. And again, a warm bath, or you can use a heating, a really easy way to do it is just to get one of those, they make them. You can probably get them on Etsy. It's like full of those little beads that you put in the microwave.
Right.
Or you can use moist heat where you can just warm up a towel in the microwave, like a wet towel. Just make sure it's not too hot. You always want to make sure the skin is safe.
And what is this whole theory of, get back up on a sprain right away? Is that real?
Not for me.
Okay. You rest your sprain.
I still believe in the old rest, ice, compression, elevation. They're actually ready for me, so I'm going to have to wrap it up really soon. But I believe in that. I also believe in active recovery, where you want to deliver oxygen to your tissues. So just because you're sprained doesn't mean that you can't do other things that might be gentle and not really too aggressive on whatever joint is injured. because anything you can do to increase your cardiac output will help deliver oxygen to those tissues. I actually say if you're not too uncomfortable, like maybe don't do the Motrin, but if you are uncomfortable, take the Motrin. I'm not really big on taking medication. That's me personally. I know other people are more big on lots of Motrin.
So it sounds like maybe even massaging the area if it's not pain. I think the best rule is if there's pain, you're going to set yourself back if you get on it.
Right, exactly.
Too. It's not like, oh, this will put me back a day. If you're on it, then you've delayed your healing by a whole week. That's how I tell my patients. Oops, sorry.
So I think they're getting
anxious. Thank you for your time. I'm so glad we were able to fit this in. We had to cancel on Friday for technical reasons with Facebook, and now we just squeezed it in by the luck.
Yeah.
By some luck. Well, thank you for being available to all of the patients here in or in all of Orange County. Your practice is awesome, and I'll post where people can find you. You have a good surgery, and help you get home to your family before too long.
Yeah, thank you so much. Thanks for having me. That was fun.
Good. We'll have you back. Thanks.
Okay, sounds good.
Bye.